Welcome to the Key Determinants of Injury module. Using the Canadian Injury Prevention Resource, this module will explore the economic and social conditions that contribute to injury risk. In this module, we will cover the following topics: risk and protective factors, key determinants of injury, how key determinants of health affect injury risk, resiliency, and populations that have a higher injury risk. First, let's review the public health approach. The public health approach includes 5 functional steps: surveillance, research on risk and protective factors, research on interventions, program and policy implementation, and evaluation and monitoring. All of these steps of the public health approach are necessary in order to successfully prevent injuries over time. This module will focus on the second stage of the public health approach, synthesizing the evidence of the risk and protective factors for injury. So what exactly are risk and protective factors? A risk factor is an attribute, characteristic, or exposure that increases the likeliness of injury. A protective factor is an attribute, characteristic, or exposure that decreases the likelihood of injury. Activity. Drag and drop these factors into the appropriate box based on whether they are a risk or protective factor for drowning. Factors are alcohol use, wearing a life jacket or personal flotation device, increased exposure to water, basic swimming training, barriers preventing access to water, water-related occupation, epilepsy, lifeguard supervision, floods, male gender, low socioeconomic status. Evidence on risk and protective factors is necessary for the development of effective prevention strategies, and 2 types of information are needed. 1. Evidence of an association between a risk or protective factor and an injury outcome, and 2. Information on the prevalence of these factors in the target population. Consider the risk and protective factors from the previous activity. There is evidence of an association between the protective factor, wearing a life jacket, and a decreased risk of an injury outcome, drowning. So developing a promotional campaign to encourage the use of life jackets seems logical, but will not be likely to result in any measurable impact on drowning injuries if the target population already has a high rate of life jacket use. Thus, in addition to evidence on the association between life jacket use and drowning outcomes, we also need to know the prevalence of life jacket use in the population in order to develop an effective prevention strategy. Risk and protective factors can be referred to as determinants of injury. Determinants describe factors that control or influence an outcome. A determinant can place an individual or community at greater or lesser risk for injury. While injuries are often attributed to the behaviors of individuals, they are actually the result of the interaction between individual, community, structural, and societal factors. Injuries do not affect all Canadians equally. Severe and fatal injuries are disproportionately experienced by individuals and populations who live in less affluent neighborhoods, have low socioeconomic status, and have low educational attainment. The likelihood of experiencing this type of injury declines as income level increases. This is Robin. Because of community, structural, and societal factors, Robin has a lack of access to resources and increased exposure to hazards. Robin's house was built with unsafe materials and is located in a low-resource neighborhood. Her family was unable to purchase products that can prevent injuries from occurring, such as baby gates, helmets, life jackets, and winter tires. As a result of social and material deprivation as a child, Robin developed a great deal of stress and had feelings of anxiety and sadness. This stress led to unhealthy coping mechanisms such as excessive alcohol use. As a result of many determinants, Robin is at a higher risk for both unintentional and intentional injury than those who have had more access to resources and less exposure to hazards. The Public Health Agency of Canada has identified 12 key determinants of health. Several of the 12 are at play in Robin's story. Can you think of some of the determinants that are on the Public Health Agencies on Canada's list? The key determinants include social support networks, education and literacy, employment and working conditions, social environments, personal health practices and coping skills, healthy child development, biology and genetic endowment, health services, gender, and culture. The key determinants of injury are the economic and social conditions that influence injury risk in individuals and populations. In this module, we will discuss the following social determinants of injury in more detail: socioeconomic class, education, employment, social, physical, and built environments, health, healthy child development, gender, health services, and culture. Income and social status, or socioeconomic status, SES for short, is a person's positioning within social or economic hierarchy in society. Several studies conducted in Canada and worldwide have assessed the impact of wealth and social position on injury risk and experiences. Although a limited number of studies have demonstrated that injuries resulting from sport and recreation are associated with being from a higher SES group, lower SES has generally been associated with an increase in injury risk. Moreover, although injuries across all socioeconomic gradients have decreased over time, the strength of association between SES and injury risk has increased. This may suggest that some injury prevention activities are having less pronounced impact in lower SES groups. This does not necessarily mean that injury prevention initiatives should target those with a lower SES. Such an approach could result in some people, such as those with an average SES, being missed. Instead, the broader determinants of injury should be addressed with a continuing emphasis on underlining social and economic conditions that promote health and safety. In Robin's story, we heard that her family could not afford to purchase certain products that can prevent injuries from occurring. This is a common risk factor associated with being from a lower socioeconomic status. Being of a lower SES can result in inequitable access to safety promotion products, such as helmet use for use with bicycles, off-road vehicles, and other recreational equipment. In addition, levels of parental supervision can differ for different children from different SES groups. And injury among children has been associated with unsafe, unsupervised use of heat sources, small appliances, playground and sport equipment, bicycles, ATVs, etc. There may also be product safety-related associations between SES and injury at the neighborhood level, as communities of lower SES may not be able to afford or may not monitor the development and the upkeep of the most up-to-date and modern safety equipment in parks, playgrounds, and other public spaces. Quick check. Test your understanding with these true or false questions. Generally speaking, higher SES is associated with a higher risk of injury. False. Generally speaking, lower SES is associated with a higher risk of injury. There may be some injury-specific exceptions. People with a higher SES may be at a higher risk for some sport and recreation injuries. 2. The strength of association between SES and injury has increased over time. True. Although injuries have decreased over time, the magnitude of the association between SES and injury has increased. 3. Injury prevention programs should specifically target those with lower SES. False. Targeting only people of lower SES groups could cause other people, such as those of average SES, who are also at increased risk of injury, to be missed. Education and literacy. The level of education a person completes is an important determinant of health and injury. Lower level of education have been linked to lower health, greater stress, and lower self-confidence, whereas higher levels of education have been associated with improved employment, higher incomes, and improved health. Read the following case study, then click on the link to browse the associated resources. Employment. Employment is a central determinant of health. In most cases, it is directly linked to one of the most important key determinants of health, income. For more information on how income affects injury risk, listen to the section Income and Social Status. Employment also relates to injury through job characteristics, type of work, and working conditions. Lower paying jobs are often associated with poorer working conditions, more dangerous environments, and greater physical demands than jobs that are just higher paying. In Canada, the most dangerous industries to work in are mining, forestry, fishing, agriculture, and construction. Another important factor relating to employment as a key determinant of injury is job security. Employees who are forced to take intermittent or precarious work have increased levels of stress and overall poorer health than those in permanent positions. They are also less likely to have health care benefits to supplement those covered under provincial health care. A number of recommendations related to reducing injury among workers have been suggested. Many of these relate to policy development. Policies should target high-risk jobs that are low-paying and under-regulated. Trivia time. Which province in Canada has the lowest rate of work-related injury? The answer is Ontario. Ontario has the lowest rate of work-related injury and also the strongest occupational health and safety legislation. Based on this, it has been suggested that increased enforcement and education and decreased exposure to workplace hazards contribute to a reduction in workplace injuries. Environment. Both the social environment and the built environment within the physical environment are key determinants of injury. We'll talk about the social environment first. Let's start by reviewing the eco-social model, a model that describes the relationship between the social environment and injuries. Activity. Drag and drop the missing social factors into the appropriate level in the model. The eco-social approach suggests that the etiology of a health outcome, such as injury, involves complex interactions between individual, family factors, and the contextual nature of built and social environments in which people live, interact, and work. The model depicts injury as arising from an interactive process between individuals and their surrounding environment. According to the eco-social model, social factors can potentially impact injuries through social networks which operate at interpersonal levels, and through social capital at the community level. So let's talk about these social factors in a little more detail. Social networks are characterized by relationships and interactions within a community or an organization. Most people integrate into society through their social networks, and this integration is beneficial for their health. Social networks can influence health through social influence and social engagement. For example, behaviors associated with injuries can be reinforced when they are confirmed by peers, or discredited when disapproved of by members of one social network. Social capital is a complex social construct, and there is controversy over its definition and nature. Social capital is related to social networks, but it is a contextual phenomenon that operates at a higher level than social networks. Social capital is the presence of strong social bonds. Trust, informal social networks, and civic participations are the main components of social capital. Basically, it is the meshing of individual networks that create a whole social network, including the complete set of relationships between all participants in the network. Although there is not much evidence surrounding the relationship between social capital and injury, some studies have shown that social capital could play a protective role for certain health outcomes, including injury, and that low social capital could be a risk factor for some injuries. Social norms generally define social organizations. In societies with low level of social organizations, violent crimes and related injuries are more prevalent. Specific social norms may encourage or prevent behaviors such as drug use, alcohol intake, and other high-risk activities that are related to injuries. So what does this all mean? Understanding the social factors that contribute to the occurrence of injuries may support prevention strategies recommended by health and social policymakers and program implementation teams. Social and behavioral factors can be modified by education, community capacity building strategies, and urban planning initiatives. Examples of injury prevention activities associated with social environmental factors might include peer education programs for high-risk behaviors and occupational health and safety campaigns that focus on the building and leveraging stronger social environments at work. Read the following case study to increase your understanding of the relationship between the social environment and injuries. Neighborhood social capital and youth injury. The objective of the study conducted by Elger et al. On Canadian youth grades 6 to 10 was to examine whether adolescents' exposure to neighborhood social capital, which was defined as levels of trust, cohesion, and cooperation, reduces socioeconomic differences in physical and psychological health outcomes. Injury was among examined outcomes, and it appeared that social capital modifies effects of socioeconomic status on rates of injuries in this population. The study included 9,717 Canadian youths participating in the 2006 Health Behavior of School-Aged Children study. It was found that in areas of low social capital, higher levels of SES were associated with a decrease in the risks for injuries, whereas in areas with high social capital, having a better SES was associated with more injury. The increased risk for injury in areas with higher social capital among affluent youth may be due to increased participation in sports. Now let's talk about physical and built environments. The built environment refers to the man-made portion of the physical environment that provides the setting for human activities. It includes urban form, physical road infrastructure, land use patterns, and transportation systems. The built environment is also frequently referred to as the physical environment, or urban form. The built environment is a common risk factor that affects many health-related outcomes, including the risk of injury. Modifying the built environment can help to prevent many types of injury, including falls, drowning, and motor vehicle collisions. In this module, we'll examine the following settings in the built environment: housing, care settings, street design, rural environments, and outdoor play environments. Let's start with housing. The housing environment directly influences health, including the incidence of injuries. Research has identified a social gradient in housing and injury risk. That is, populations with low income and low educational attainment are at a higher risk of injury in the home. Causes of housing-related injuries include structural conditions from substandard housing, lack of safety equipment, low income, and chronic material deprivation conditions. Structural conditions in the home are associated with increased injury risk. These conditions include exposed heating areas, unsecured upper story windows, low window sill heights, slippery surfaces, breakable window glass, and poorly designed stairs with poor lighting. Residents of high-rise buildings, especially children, are particularly susceptible to falls from windows, balconies, and faulty or steep stairs. In any home, lack of safety equipment such as the gates or handrails can increase the risk of injury for seniors and children. In fact, the home environment is identified as a primary factor leading to unintentional injuries in children in low-income households. A substantial body of research demonstrates a social relationship between housing insecurity and the risk and incidence of preventable injuries and fatalities that occur in the home environment. Next, we'll examine care settings. Long-term care, or LTC facilities, provide 24-hour professional supervision and care for individuals who have complex care needs and can no longer be cared for in their own homes or in an assisted living residence. The majority of LTC residents are older adults, age 65 plus, and typically have behavioral or cognitive problems or complex medical conditions. Hospitals have a more diverse patient population. However, older adults accounted for a high proportion of this population. The LTC environment is of particular concern to healthcare providers, as the rate of falls among LTC residents is 2 to 3 times that found among community-dwelling older adults, and approximately 30% of falls in LTC residents result in injury. Within care settings, many aspects of the built environment are associated with an individual's risk of falling and/or subsequent likelihood of injury in the event of a fall. Environmental interventions have been observed to reduce rates of falls in both long-term care and hospital settings. Click each image to hear more about the different types of environmental interventions. Flooring and transitions. When designing hospital and LTC facilities, a common approach to minimize risks for falls is to use non-slip, non-glare, and even surface with no inclined steps or loose carpets, floors, and floor coverings. Fall mats. Another way to soften the landing of falls is to provide padding between the impact site, like the hip or head, and the landing surface through the use of fall mats or bedside mats. Lighting. Older adults may experience changes in their vision as a part of the normal aging process and/or a function of disease. Proper lighting in care settings is therefore important to reduce the risk of falling for older adults with low vision, but also for the ease of all individuals navigating through the infrastructure. Clutter. Clutter is perhaps the most established environmental risk factor for falls, indicated mostly in trips and stumbles, which according to real-life videos of falls in LTC, account for about 21% of falls. To reduce clutter leading to falls, care settings should offer adequate space for storage of mobility aids and equipment. Handrails and grab bars. Care settings are also encouraged to incorporate handrails and grab bars to facilitate safe navigation and weight transfers, especially on and off toilets. Toileting aids. Toileting aids can help the user to function independently when using the toilet. Raised toilet seats, grab rails, toilet frames, and self-lift seats are all aids to assist with transferring on and off a toilet. Furniture. Interactions with furniture can lead to falls arising from a loss of external support or incorrect weight shifting. When designing furniture to prevent imbalance arising from loss of external support, there seems to be a need for automatic locking mechanisms, which cause mobile devices to become relatively immobile as soon as there is a transfer of weight. Aside from helping to prevent falls, furniture can also be designed to mimic the risk of injury in the event of a fall. Street design is an important consideration in built environments. In many countries, the primary consideration for street design has been motor vehicles, with less attention to pedestrian or cyclist safety. High-speed roads have been built in residential areas, while play and walking areas have been overlooked. Traditional road safety interventions have targeted individual road user behavior change, but these have not had impressive results. Built environment approaches focused on street design have more evidence supporting their efficiency. Almost half of the strategies promoted through Canada's Road Safety Strategy 2015 are directed at street design. Modification of the built environment, such as street design, shifts some of the responsibility from the individual and benefits the community as a whole. 3 important mitigation strategies are speed control, separation of motor vehicle from other road users such as pedestrians and cyclists, and improved visibility of vulnerable road users. Although there is a promising evidence supporting the effectiveness of built environment street design interventions, there is a need for more well-controlled studies. In Canada, the rural environment is an especially important aspect of the physical environment. Canada is a vast country with 95% of its landmass considered rural, northern, or remote. Over 6 million Canadians live in rural areas, representing 19% of the Canadian population. Living in a rural environment poses unique challenges related to injury prevention due to different social, economic, and built environment conditions compared to urban areas. Injury morbidity and mortality is considerably higher in rural compared to urban areas. People living in rural communities generally need to travel longer distances and on more dangerous roads. Therefore, injuries and death due to motor vehicle collisions are much more common. Improved rural road conditions and raising road safety awareness need to be explored. Certain rural-based industries, such as farming, have high levels of occupational hazards, and attention to occupational health and safety issues specific to rural settings is important. There is a need for increased awareness and uptake of safety devices related to fire hazards and drowning in rural areas. Future research should explore whether conventional strategies, mostly developed by urban program planners for urban residents, are equally effective in rural settings. The final type of built environment we will explore in this module is outdoor play environments. Despite increasing evidence in support of challenging play, the balance of safety versus risk is an ongoing issue. In recent years, many playgrounds have been altered to improve safety, often resulting in the KFC playground comprised of a kit of play equipment, fence, and a carpet, usually rubber surfacing. The KFC playground has been criticized for offering little challenge and few natural elements. Providing children with play environments that change, give children the chance to create and imagine, and offer them not only physical but social and cognitive challenge is essential to healthy child development. Thinking beyond the KFC requires us to approach play design with the objective of expanding play opportunities rather than restricting them. Arranging natural materials to create spaces within the playground and placing materials in a way that encourages diverse interaction will inspire children to engage with their environment and learn from it. Flexible play spaces with a variety of diverse play opportunities allow children to determine the level and types of challenges they need to explore for their own developmental benefit. Creating versatile play environments that are inclusive of risks rather than averse to them will ultimately benefit children by teaching them to manage risk in their own environment. An optional case study. If you are interested in seeing 2 examples of how playgrounds were transformed from the KFC style to versatile play environments, click on the link provided and check out page 199. Activity. Check your understanding of social, physical, and built environments as key determinants of health with this quiz. Health services. Access to health services is a key determinant of injury. In this module, we will focus primarily on access to trauma care. Minimizing the time between injury and trauma care improves outcomes. Prolonged discovery and transport times have both been identified as important variables contributing to these delays, and because they seem particularly relevant in rural environment, careful study of rural trauma victims is necessary to identify ways of improving access to trauma care. Evidence suggests that rural trauma victims experience worse outcomes compared to those in urban environments. Overall, persons injured in rural environments are nearly 50% more likely to experience a fatal outcome. Canada has particularly unique considerations for trauma care access due to its geographic variation, substantial landmass, and wide population distribution. Furthermore, as trauma systems are provincially administered in Canada, policy-based differences in access are possible. Defining which populations have reduced access to trauma care becomes an important prerequisite to designing policy tailored to improving the universality of trauma care for Canadians. Given the emergent nature and mandated universal access to care, trauma has traditionally been thought to be devoid of racial biases. With many of its rural and remote communities largely inhabited by First Nations and Inuit peoples, race and spatial access to trauma care may be more relevant in Canada than previously appreciated. A recent meta-analysis examining racial disparities in trauma care in the United States demonstrated non-white race and socioeconomic status as independent predictors of increased mortality following trauma. Canadian studies are needed to determine whether this also occurs within our system. Although recommendations for triage to a trauma center could be independent of a race or gender. It is possible that the unconscious biases affect access to trauma care for some patients. Trivia time. In Ontario and Quebec, greater than this proportion of residents live within a 1-hour drive of a Level 1 or Level 2 trauma center. A. 75%, B. 80%, C. 90%, or D. 95%. The answer is B. In a study by Hamid et al., a total of 32 Level 1 or 2 trauma centers were identified across the country. And although Ontario and Quebec had 84.8% and 86.8% of the respective population within 1 hour's drive to one of these trauma centers, access to comparable centers in the Prairie and Maritime provinces was significantly lower. Gender. Gender is a very significant determinant of injury. For virtually every kind of injury beyond 2 years of age, Canadian boys and men are 2 to 4 times more likely to sustain an injury than girls and women, and their injuries are more severe. The myriad of risk factors that contribute to increased injury liability for boys and men are not yet well understood. Lifestyle and personality characteristics and traits, such as impulsivity, sensation-seeking and risk-taking behavior, differences in socialization during childhood, attributions for how long and why injuries happen, along with a variety of other factors, have all been investigated with a view to better understanding why a strong gender discrepancy begins early in life and persists along the life course. Although Canadian boys and men are far more likely to sustain an injury than girls and women at virtually any age, most injury prevention programs do not appear to be sensitive to these gender differences, and gender-based evaluations are typically not conducted. Although there are expectations to this pattern of risk, such as the risk of self-harm in teen girls and LGBTQ youth, and fall-related injury in older female adults, more work needs to be done to take the higher risk for injury for men and boys into account, and to reduce the significantly higher rates of morbidity and mortality due to injury for both men and women across the life course. Activity. Using the Canadian Injury Prevention Resource Chapter 3.8, fill out the following chart to summarize the factors related to gender as a key determinant of injury by age group. Culture. In this module, we will discuss culture as a social determinant of health by focusing on newcomers to Canada and Aboriginal populations. First, let's talk about the injury prevention issues related to the growing and diverse immigrant population in Canada. Moving from one's native country to a new place is a stressful life event. This process often involves learning a new language, adjusting to a new environment, often with a different climate, and culture. An individual's sense of community and cultural identity is radically altered by these changes. Dress codes, food practices, and social customs in the resettlement country can all differ, resulting in a cluster of stressors. Combined with the challenging socioeconomic prospects, a common issue for immigrants who often struggle to find well-paying jobs that reflect their education and experience, new immigrants tend to experience significant stress. In terms of how this experience is related to the rate of injury in the immigrant population, there is a scarcity of information about immigrant children's health, particularly as it relates to childhood injuries from falls, motor vehicle collisions, burns, and other causes of injury. Current data on injury rates in adult immigrants is limited, but suggests that adult immigrants, particularly men, are most likely to experience injury that requires medical attention in the workplace. Many newcomer families lack information and knowledge about healthcare services generally, and injury prevention specifically. Culturally appropriate information would better connect families to appropriate healthcare and preventative services. Ultimately, promoting optimal child health and well-being among new Canadians requires a collaborative, multi-organizational, and multifactorial approach that tailors a program based on the understanding of the behaviors, cultural norms, lifestyles of these communities is required. This table summarizes some of the potential barriers and enablers to injury prevention among newcomers to Canada. As in the rest of Canada, injury is the leading cause of death for the Aboriginal population between the ages of 1 to 44. However, among Aboriginal peoples, injury rates are considerably higher. Moreover, First Nations peoples living on reserve and in northern communities have higher injury rates compared to other Canadians. A 2002 to 2003 study of First Nation children living on reserve estimated that 17.5% were injured compared with 12% living off reserve. The reasons for the differing injury rates and risks for injury among Aboriginal populations are complex. Societal factors, including health, educational, economic, and social policies, serve to maintain the economic and social inequality between many Aboriginal populations and their mainstream neighbors. Colonization, which affected language, culture, land rights, and self-determination, resulted in poverty, substandard housing and overcrowding, inadequate water and sewer facilities, and barriers to education. All recognized risk factors for injury. Case study. Click each section of the pie chart to hear more about the associated leading cause of injury among Aboriginal people. Motor vehicle collisions. The high rates of motor vehicle crash deaths is most often attributed to the fact that Aboriginal communities are remote and isolated. Road conditions are generally poor, and more hazardous machines such as all-terrain vehicles and snowmobiles are frequently used for transportation. In addition, when a collision occurs, emergency services and healthcare facilities are often hard to access. One study found that First Nations people are 5 times more likely to suffer severe trauma resulting from a motor vehicle collision compared to a non-First Nations people. Other studies have shown seatbelt and child restraint use is lower in rural Aboriginal communities, resulting in a significantly increased risk of injury and death. Additional contributors to collision incidents include inadequate enforcement of restraint legislation, lack of helmet use with all-terrain vehicles, and substance abuse. Poisoning. Like other types of injury deaths, poisoning-related deaths seem to be more frequent among First Nations populations. In an early study in British Columbia, during the period 1991 to 1998, age-standardized mortality rates from poisoning were 4 times higher for First Nations people than for other BC residents. 3.8 versus 0.9 per 10,000 population. In a more recent study in the same province covering the period 1992 to 2003, the rate of death from poisoning among First Nations were on average 4 times higher among First Nations, with rates among 25 to 44-year-old people representing the highest in both First Nations. 70% of poisoning deaths among First Nations were in this age group, and general populations, 6.9 versus 1.7 per 10,000 population. A study conducted in the Sioux Lookout area suggested that accidental poisoning was prevalent in children under the age of 4, 441 per 100,000 for boys and 408 per 100,000 for girls. However, the rate for adults in this area was also high, primarily due to high rates of alcohol poisoning. Alcohol poisoning occurs when the amount of alcohol in the body exceeds tolerable limits. Toxic levels of alcohol can lead to death, either directly or by affecting judgment, coordination, balance, and reaction time. In British Columbia, where alcohol levels was tested, nearly 90% of all First Nations injury deaths had a blood alcohol concentration of 0.08 or higher. Suicide. Suicide accounts for roughly 1/4 of all Aboriginal injury deaths, with rates 3 to 4 times the Canadian average. Rates of suicide differ by geographical location and age. However, young First Nations and Inuit people are at significantly greater risk. Compared to overall Canadian rates, suicide in many Aboriginal communities and populations has continued to rise over the past decade. Although there are large variations across populations, the overall suicide rate among First Nations communities is approximately 2 to 4 times higher. Over a third of all deaths among Aboriginal youth are attributable to suicide, and between the ages of 10 to 44, Aboriginal peoples on reserves are 5 to 6 times more likely to die of suicide than their peers in the general population. The rate among Inuit communities is 6 to 11 times greater than the Canadian population. From 1999 to 2003, the suicide rate among Inuit was 135 per 100,000 population, 5 times higher than that of First Nations, 24.1 per 100,000 population, and 11 times higher than the rate for all Canadians, 11.8 per 100,000 population. Between 2004 and 2008, Inuit children and teenagers in Inuit Nunavut were more than 30 times more likely to die from suicide as were those in the rest of Canada. Furthermore, half of all deaths of young people in Inuit Nunavut were suicides, compared with approximately 10% in the rest of Canada. Fire and/or flames. Increased risk of death from fire in Aboriginal communities is due to a higher proportion of smokers in the home, wood-framed substandard housing, lack of working smoke detectors, increased travel times for fire rescue personnel and equipment, as well as a shortage of trained firefighters. A previous study of First Nations communities in British Columbia demonstrated that injury fatalities due to fire were 8 times higher than the provincial average. First Nations children are particularly vulnerable, where studies in Manitoba report children are 5 times more likely to die in a house fire, and that some 31% of fire deaths in Aboriginal populations occurred in children between 1 and 14 years of age, compared with 16% in the general Canadian population. Drowning. In 1996, drowning in the Aboriginal population was 6 times higher than the Canadian average, with rates in children as much as 15 times higher. More recent data comparing Aboriginal to non-Aboriginal data were not located. While Aboriginal peoples comprise about 4% of the Canadian population, they account for approximately 26% of drowning cases that involve a snowmobile, 16% of drowning cases after a fall into water, 10% of people who drowned during recreational aquatic activities, and 9% of those who drowned relating to boating activities. Aboriginal people are at increased risk of drowning because of proximity to open bodies of water, low use of flotation devices, and alcohol use. It is reported that only 6% of Indigenous drowning victims were wearing a personal flotation device. Alcohol use is also reported as a significant factor in drowning deaths. In the 1998 Red Cross drowning report, 64% of victims had a blood alcohol level higher than the legal limit, compared to 27% for non-Indigenous drowning fatalities. Other risk factors include regional location, specifically bodies of water with colder water temperatures, a risk factor for death from hypothermia. Congratulations, you have completed the Key Determinants of Injury module.